Hospital has started though, about half strength now.
Mm-hmm.
Are you
But
doing elective cases now?
yes, I mean, people who were on waiting list in March, we managed to finish them now in August. So new patients have also started coming in. It's all under a lot of pressure. Everybody is worried because unlike many Western places where there's a clear segregation of hospital for COVID and other hospitals will remain non-COVID, government has taken over most of the hospitals and are packing some part of the hospital with COVID patients. So segregation becomes very. Henry has seen. We have three wings of the hospital. So one wing is completely taken over by the COVID force. Our ICU, our operation theater is okay, so we can manage. But there are many people who are finding it very tough. Good evening, Salman.
Hi guys, how are you? I'm sorry, I was just coming back from the clinic and I was listening to your talk, but I wanted to check in once I'm sitting in my at home. I'm back home anyway. So actually, it's quite good in Pakistan, and for whatever reason we are not doing anything good.
Surprised, our neighbors are not so badly affected.
Because so we are not following rules. We are doing exactly what Indians are doing or what French are doing as well. But for whatever reason, we are pretty all right. So our numbers, for example, for today, for whole of the country were 500 new cases with only 4 deaths.
Yeah.
So your numbers resemble Costa Rica, only that you guys are, several million more in population.
Absolutely. The numbers are just astounding. I mean, don't want to look at them.
I think you guys are probably doing a bit too much of outing. I think it's very difficult to control whole of India altogether. It's very, very tough.
No, everything has boomeranged. I mean, the lockdown period was so good that as soon as it finished, it had just exploded.
Yeah.
Just a recommendation. If any of you has ever read a book that's very good on how epidemiology and science and all things come together, there's this book that's called House on Fire, which is basically how it describes that smallpox was tackled in India. We're free from it worldwide.
Yes, yes.
And the biggest effort was taken in India. So very interesting book.
No, I think 2 things they have been able to eradicate: smallpox and polio. But it has taken several years.
Yes.
One good thing that is happening, Salman, is along with COVID, because of the respiratory, hygiene has improved, tuberculosis has gone down.
So the other theory with India, Pakistan is that if you've had a BCG vaccination, your chances of having COVID goes down as well. So, there's a big study going on in multiple centers in Pakistan regarding this. So let's see what it comes out to.
Yeah. I'm skeptical regarding the vaccination. And you?
It's too early.
Other viruses, coronavirus, was very difficult to get the vaccination, as far as I know. I think it's like with the flu. You get in vaccination, sometimes helps, sometimes not.
Yeah.
I'm afraid it will not be a big solution. Hopefully I'm wrong.
I think as you say, it all depends on which vaccination takes off and which country has a bigger pull to pull the vaccination off. So it all depends on various factors, a lot of politics involved, obviously, and a lot of money involved in this. but we know very well that all these, so, you know, there are 3 big trials going on. Rest of them are just following them. And the question is that the initial results might be out by end of November. And then we would have a fair idea that how many are actually going to be in the play compared to the whole world. So let's see.
Okay, so it's the hour. Would you like to start, Salman? And then I'll follow.
Sure, no problem. Guys, good evening. It's good morning wherever you're from. Good afternoon or good day, whatever you call it. It's wonderful to start this. I think I have my hats off to our pediatric colleagues who have taken this up. And this is ISPN course, and we have these 8 sessions in which we have 16 people giving lectures, and they were all topics were chosen by Adrian, and the speakers were chosen by him as well. I'm grateful for that, for doing that. And the idea is that our young fellows who want to be pediatric neurosurgeons, they want to take it up, and many people don't have proper training in pediatric neurosurgery, and to do this would be amazing. What we're going to do is, this is a certificate course. So people who attend more than 6 sessions will, 6 or more than those sessions will receive certificate for this. Obviously, it will be written on your certificate, how many have you attended. So this is session 2, and we have 2 brilliant friends with us, both of them amazing surgeons and very good and very dear friends and great persons. You know, their personality is super. I don't know who's starting out. Do I know?
It's Henry. Henry goes first.
Adrian decides the order.
Boss makes a decision.
Okay.
Hi, guys.
So I will take it from there, if you will. So again, this is an educational activity on behalf of the ISPN. I guess now we have also 4 members of the IFNE. So it's a conjoined effort. And we would like to start first. I would like to introduce my dear friend and colleague, Dr. Henry Schroeder, which, as you all know, has been a past president of the IFNE. He is one of the pillars of neuroendoscopy worldwide, and he is the head of the Department of Neurosurgery at the University of Greifswald in Germany. So without further introduction, I will hand over to Henry so he can give us his lecture on neuroendoscopy in pediatrics. Henry, please proceed.
Yes, thank you very much, Erin, for the nice introduction. Thank you, Salman, for the invitation. Thank you to the ISPN for the opportunity to speak here. And my topic was neuroendoscopy in pediatrics general, but I think it is too much stuff. I cannot handle it in 30 minutes. Of course, we use endoscopy more and more in endonasal skull-based cases for craniopharyngiomas and chordomas, and we use it also for endoscope-assisted microsurgery. But I just want to focus here on the pediatric hydrocephalus because of time limitation. I think it's very important that you have good equipment when you do an ventriculoscopic surgery, especially in children. So we use 2 endoscopes with different diameter. And for me, it's very important that this endoscopic system has the endoscopic sheath. So the trocar is inserted into the sheath is introduced into the cavity, and then I come with the ventriculoscope. This sheath is very important because it creates space if you have very narrow cavities. So you go a little bit back with the endoscope and you can use the room, the space in front of the lens for dissection. Also, I can use that retractor. I can retract the fornix or some brain tissue over membranes, like here in this cavum septi pellucidi. The outer diameter is 6.1. What is more important is the inner diameter of the large working channel. This is 2.9 millimeters. So I can use a big suction tube to evacuate hematoma for in endoscopic lavage, for example. I can use scissors, large scissors, and other instruments if you want to penetrate an arachnoid cyst. The outer diameter of the sheath is a little bit large for children, is 6.8. That's why we have a little otoscope, which has a smaller diameter, but the same design. The outer diameter is 3.6 millimeter and the main working channel is 1.6 millimeters. And this is used for all kind of ventriculoscopic surgery to restore CSF circulation, to make a septostomy, to make an ETV, for a tumor biopsy in narrow ventricles. And also we have an endoscopic sheath for that. So there's a big difference in diameter, and therefore usually we try to use these smaller ones if possible. Regarding the optical quality of the lenses, the difference, because the Lotta has a 2.7 millimeter optics and this is only 1.2, but you see, because it's a rodlet system connected to an HD camera, the quality is still very good, much better than compared to the fiber scopes or semi-rigid scopes, what we used before. And what we frequently use in children is this conical shaped trocar. There's an endoscope inside, so you can look where you go. And because of this conical shape, you can dilate a small foramen of Monroe, for example, to go in. This is available for the smaller scope as well as for the standard Lotta. And I don't rely on an assistant holding the scope, because usually a resident is doing the surgery with me, and mostly they are not very experienced. And I think it's dangerous if they move unintentionally the ventriculoscope shaft too much. We may damage the fornix or the veins. That's why I prefer to have it in a holding device. It's a pneumatic arm. It's very easy. You just press this button and then you can position it in all directions. And for me, it's better than to have it in the assistant's hand. It's different to endonasal. Endonasal, always an assistant is holding the scope, but in the nose, nothing can happen if you move the endoscope around. And then for inspection, we have 3.3 millimeter diagnostic scope to look into all corners. This is our setup. Usually we sit, sometimes we stand, and we have the navigation screen and the endoscopic screen in front of us. So what are problems when you do endoscopy in very young infants or premature newborns? The brain tissue is very vulnerable, so you have to be very careful. It can easily bleed, so you should not touch the ventricular wall if possible. Additionally, frequently and purely endoscopic procedure is not successful in solving the problem of hydrocephalus because of CSF absorption problems. And the etiology is of a major importance in our experience. So for example, you see here a child with a hydrocephalus. This is an MRI at the day of birth, and you see severe hydrocephalus, almost no brain. You might say, man, this child has not a chance of a good life. But if you treat the hydrocephalus effectively, you see how much brain tissue comes suddenly. So the initial image is clearly no clear indication to do nothing or to have only basal care. I think the best indication for endoscopy is, of course, obstructive hydrocephalus, because we have the chance to get a patient shunt-free. There are several techniques: septostomy, foraminoplasty, ventriculostomy, aqueductoplasty, and stenting, which can be performed. Before you start with your endoscopic procedure, you need a very good MR imaging. And of course, MR imaging is today standard of care. And if you have access to an MRI, of course, you should have an MRI. And besides the standard T1 and T2 weighted images, we perform an inversion recovery turbospin echo sequence. This is flow sensitive. It's similar to phase contrast, but takes less time and shows also is there flow in the aqueduct or not. And then the other sequence, what we use is a high resolution T2 weighted imaging. This is constructive interference steady state with the Siemens machine, what we use. And you see all the structures which are important. You see the bulging of the floor, bulging of the lamina terminalis. You see a pre-stenotic dilation of the aqueduct, so clearly here's an aqueductal stenosis. And you see also the membranes in front of the brain stem. So this sequence for us is very important when we plan our procedure to treat patients with hydrocephalus. And selection of approach is also very important. It's different to open surgery. In open surgery, you can have different angles of view, but in endoscopy, you place your borehole and this is the only angle you have. That's why it should be placed accurately. For example, this patient had a hydrocephalus and a tumor in the aqueduct. So our aim is to take a biopsy and to make an ETV. Can we do that in this patient? Via one borehole? Usually, yes. You place the borehole not at the coronal suture, but 2 centimeters in front. Then you have access to the floor and you have access to the posterior part of the third ventricle, but only if the bottleneck of the approach is wide enough, and that is the foramen of Monroe. And in this patient, you see it's very tiny. So it would be ill-advised to go to both areas via one borehole. You need a flexible scope to make both procedures via one, or you make two trajectories. The foramen of Monroe is very important, and that's why you have to look what is the size of the foramen, and then you plan your approach according to this information. That's very important because I have seen severe damage to the fornix and damage to the patient because the surgeon did not look at the foramen of Monroe. So ventriculostomy is certainly the most frequently performed procedure. We place the borehole exactly in front of the coronal suture. And then we have the floor identification of the infundibular recess, mammillary bodies. Here we see a perforator from the basilar. And where should be our perforation? It should not be at the thinnest part of the floor. That would be behind the perforators. And that is the risk that you rupture one of the perforators and you have a disaster. So the ventriculostomy should always be in front of the basilar, just behind the clivus. Also not too close to the infundibular recess because that may cause endocrinological problems. The best, ideally, usually is halfway in between infundibular recess and mammillary bodies, just in the midline. And what is very important after your fenestration, you do not open only the floor, but also the Lilliquist membrane. You have to see the subarachnoid space with the basilar artery. If you go too far anteriorly, it may happen that you end up in the subdural space. That's why it's important. You look in, this is a view with a 30-degree optics. You see, aha, I'm in the subarachnoid space. That is the right way to go. So just one example, this was a child which was sent to us with a huge tumor, which was considered to be inoperable. You see almost the whole hemisphere is tumor. Chemotherapy was tried, but tumors grows further on, and there was an extensive dilation of the temporal horn. When you look, there was a ganglioma. If you look to the T2-weighted image, you see that this brain seems to be compressed. Here you see the sulci and the gyri, but here everything seems to be compressed. So I think all the basal ganglia seem simply pushed upwards. So there is a chance to make a surgery. We made the surgery. It was a very bloody tumor and the child was 1 year old. So we lost a lot of blood. So we had to stop after half of the resection. And then we came back after 3 months and took the second half. And then the child was doing well. Initially shows very good post-op image. And then you see 1 year and a few months later, he developed hydrocephalus. When you look to the saturated image, you see there's an aqueduct obstruction. Although there was never surgery there, but obviously because of the blood, which was going to the CSF spaces as well, there was an occlusion. And he underwent 3 times an ETV in his home area. He came from the south of Germany, and then he came to us, and you see the floor is completely closed by scar formation. Here we look with a 45-degree endoscope to the aqueduct, and it's clearly obstructed as a result of the blood I get from the tumor operation. And you see there is a very tough Lilliquist membrane which has to be opened. And then if you look further down, we see there were a lot of arachnoid adhesions in the prepontine area. And I think that is the reason why this procedure failed, because they did not open up all these arachnoid membranes in front of the brainstem. And this will interfere with the pulsatile flow, which is very important that this is restored. So we take scissors and we cut all these arachnoid membranes, multiple levels, to get access to the lower area. And these are very tough membranes, so it's not only you cannot only do it with a blunt perforation, but you need scissors. But now you see we can go in front of the brainstem, and here we see abducens nerve, and below there are no membranes. So here the CSF flow seems to be free. You see ICA running here to 7 and 8. And this, in my opinion, was the problem in this case. And you see the flow void sign as a result of the fenestration. The ventricles came again down to normal. And 3 years after ETV, he was fine. And now he is finishing school almost and is still doing well without a shunt. So I think it's very important. The message of this case is that we have to open these arachnoid membranes, which might obstruct the prepontine flow. And this pulsatile flow is very important that an ETV is working. So another case was interesting. He came to us when he was 10 months old. Initially, he got an ultrasound after the birth, and it shows a hydrocephalus. But he had a normal development, so nothing was done. Also at 6 months after birth, still motor development was normal. But at 10 months, our pediatrician said there was a delay in the cytomotor development. And the MRI shows the hydrocephalus, and it shows here some kind of vessels in front of the aqueduct. Looks very strange. And if you look to the axial view, you see a vessel going through the midbrain, and it goes here around the aqueduct. So we were not sure what it is, but he has a hydrocephalus, so we went in with an endoscope. You see here a fornix, coral plexus, thalamostriate vein. Then we go in with the endoscope carefully. We always look at the margin of the sheath, and you see an atypical vessel here, which is also obvious. And we looked at 45 degree with a 45-degree endoscope to the back of the aqueduct, and that was very strange. You see, this is a DVA, a developmental venous anomaly, occluding the aqueduct almost completely. And then the question is what we do. I think aqueductoplasty is not a good idea, but an ETV should be the best option in this patient. Here we had to use the old semi-rigid endoscope. That's why the image quality is not so good. So we open up the floor and we open up the membrane. And then we had a good ETV with a good flow. And you see the ventricles came down in size, and he had a very good development further on. And so far, he does not require shunt treatment. This was another very interesting case. This was a young girl. She presented initially with hydrocephalus. This was an incidental finding. She had no complaints, nothing. That's why no treatment was performed. And then she came back with progressive nausea, vomiting, gait disturbances, and she had also panic attack with respiratory distress in the upright position. A new MRI was done, and what you see now is there is a secondary Chiari with compression of the foramen of magnum, and the disturbance of CSF flow. So she developed syringomyelia and symptomatic hydrocephalus. The question is, what would we do in this case? I think it's pretty clear. The reason is the hydrocephalus, so we want to treat first the hydrocephalus, and then we see what's happening. And it was really interesting how fast the syrinx resolved after we just make an ETV. So we did not make any decompression. All of what Artugol recommends is always fixation. So we did nothing, just an ETV. And this patient is doing fine since then, without the need of shunt, without the need of any decompression operation. Then another case, that was a 12-year-old boy. He had intermittent headache and recurrent nausea about 2 days before admission. And at the day on admission, he started vomiting. And then you see he has a large hydrocephalus, bulging of the floor. There seems to be a lesion in the aqueduct. And then during the admission process and obtaining the consent with the parents, she became almost comatose. And the pediatricians, they ordered a new MRI. So they ordered not us immediately for surgery, but they made first an MRI, and you see the tumor is sucked in the aqueduct. So that was very interesting because the tumor was pedicled exactly here. at the anterior end of the tectal plate. This was the origin of the tumor, and because of CSF flow, it was sucked in and occluded completely the aqueduct. And then we made emergency ETV, and we resected the tumor away, and this was an ependymoma. So ETV and tumor resection was the treatment in this case without the need for shunting or other procedures, no microsurgery. The big question is always, is age a prognostic factor in endoscopic treatment of hydrocephalus? And my opinion is yes, age is a prognostic factor, but there are also papers saying no, only etiology is a prognostic factor, but I don't agree with that. I think age is also a problem. This was a young child, 13 days old. The mother came to us because we offered an endoscopic treatment and she does not want to have a shunt. You see this big hydrocephalus and here an aqueductal stenosis. So we make the endoscopic treatment. Again, this is a semi-rigid scope at that time. We did not have the little Lotta. We open the floor. It's a very vulnerable tissue, so you must be very careful. There's almost no feedback if you perforate the floor because the floor is so thin and vulnerable. Then we take the Fogarty balloon catheter, which is pre-filled with saline. We open it and you see the pituitary gland here. This is a clivus. And here you see the basilar artery and the subarachnoid space. So technically it went very well. And then you see after surgery, the ventricles came down a little bit. There's a wide opening in the floor, but still the child has wide ventricles. But if you look, the ETV was done here 2 weeks after birth, and you see slowly the head circumference went down, and in the further course, it follows the 80th percentile, I guess, in this area. But it was not crossing again. So that's why no shunt was inserted. But you see still wide ventricles, not as small as what we see sometimes after shunting. It was 5 years after ETV, and then we saw her later. She came back to our institution in 2017. You see no further decrease in size, but also no further dilation. And she was still doing fine, made their finished school and was working in her profession. So 13 years after surgery, wide open ETV can be a solution, but wide ventricles. So the question remains, is a wide ventricle bad or not? And there is a nice paper by Abhaya Kulkarni. They investigated 23 children, and they found that there's no association between the ventricular size and the cognitive outcome. So even with wide ventricles, you can have a normal neurocognitive outcome compared to other treated children with a shunt. So wide ventricles seems to be not big a problem, and this was further confirmed by the so far only prospective randomized study comparing ETV and shunting and children under the age of 2 years presenting with hydrocephalus due to aqueductal stenosis. And here also they found there was no difference between patients treated with ETV and shunt. So even if you have a little bit wider ventricles, your life can be the same like with the shunted ventricle, which is smaller. There was another patient, almost the same. It was pretty the same case. We did the surgery a little bit later, but you see wide ventricles, aqueduct stenosis. We did the surgery, ventricolostomy in February 2009. And you see initially there's not much change in ventricular size. Ventriculostomy is wide open, but also no pressure signs. So we followed the child, but then you see slowly but steadily it was crossing the percentiles and was outside the percentiles, and then finally a shunt was placed. And the question is, was that necessary or not? But I think if it's crossing the percentiles, so it goes far away, it should be done, in my opinion. So our own experience with pediatric cases was published in 2009, and we found the success rate of ETV in patients presenting with occlusive hydrocephalus is around 70%. And the radiological benefit means a decrease in size we saw only in 56. So some patients even are doing well without a major decrease in ventricular size. And what is clear from our experience is that age is a risk factor. So below of 6 months, we have a high rate of shunt dependence. So in my opinion, etiology as well as age is a problem. But also hemorrhage and a history of infection is a problem. If you open the floor of a third ventricle and you see this scarred fibrotic basal cistern, I think then it makes no sense to try to open it up. If you have a few membranes and it's not all the room is with fibroid adhesions, then it makes sense to open these membranes, like in this post-operative case I showed earlier. But if you have the history of a post-hemorrhagic hydrocephalus and you see this cistern, you know it will not work. So then a shunt is indicated. And there was a nice paper. There was evidence-based guidelines should be, but there was not evidence-based usually because there is no clear evidence. And that was also a recommendation. There is insufficient data to recommend the use of endoscopic subventriculostomy in premature infants with post-hemorrhagic hydrocephalus. So in post-hemorrhagic hydrocephalus, in my opinion, we should insert a shunt. If there would be later a shunt insufficiency when the child is 2 years or older, then of course we can try to make an ETV if there is an obstruction. If it is a communicant hydrocephalus, in our experience, it's not working well. But we have also aim of surgery in shunted procedures. When do we do surgery? Although we know there is a shunt dependence, then we want to have a simplification of the shunt, but sometimes we don't know the patient needs a shunt, then we do the surgery and try to remove the shunt, but you never know exactly is this working or not. And sometimes we use an endoscopic procedure just to get sometimes free of a shunt. So we make an ETV, for example, although we know it will not work forever, but maybe it's 1 week, it's fine to control the hydrocephalus, and we have a time period where we don't have infected material inside the brain. We also made an investigation. We had 30 patients, and in 60% we have been successful to get the patients free of a shunt. If I have a shunt-dependent patients, then I want to use the endoscope if I have compartment formation, especially in multiloculated hydrocephalus. There also all techniques can be applied to make a simple cavity which is then shunted. This was one child with meningoencephalitis with streptococci, and he received a VP shunt 3 months at 3 months of age. And then there were multiple revisions. And when he came, you see there's a big compartment, there's another compartment, then there's a third ventricle and a very wide fourth ventricle. And there were 3 ventricular catheters. One is here on the right side, one is on the left side. And so the aim here on the left side, and the aim was to make one cavity and to connect all compartments. So when we look in, this is the left side. It's a very wide foramen. There's a very wide ventricle on the left side. You see here the ventricular catheter on the left. We make first opening. This is the approach where we go to the third ventricle. It's a big membrane, so we can look in, and you see here, this is the floor of the third ventricle. This is a clivus, and this is a very wide aqueduct. Gives us access to the fourth ventricle. So we make a wide fenestration. Then we go in, we look down, floor is very thin, this is the clivus, infundibular recess, here are mammillary bodies. We can look into the fourth ventricle because the aqueduct is very dilated, and you see that the foramen major and also Luschke are completely closed. So we make no attempt to open this because I think it will close again because there are a lot of arachnoid membranes around. So we did not do that, although it's described in the literature. And then we make a subventriculostomy and we make more fenestrations, and we removed all the ventricular catheter, and then we placed a long catheter which goes from the borehole through the left ventricle to the third ventricle into the fourth ventricle. So all compartments are drained by one ventricular catheter. That is the aim in these procedures. This was a child with a premature, also with a premature newborn with post-hemorrhagic hydrocephalus. Like all patients, received a shunt. See, this was the image at the time of the hemorrhage. Then a VP shunt was placed later on. And then what is very typical is a presentation with a trapped fourth ventricle. And what is the treatment of choice in these? So we tried to connect the supratentorial ventricular spaces via the aqueduct with the fourth ventricle. So a stenting procedure. And then we connect the shunt to the stenting, to the stent. See, this is a cyclops ventricle. There's no septum pellucidum. It's a corpus callosum. This is the fornix, foramen of Monroe. And you see my endoscopic sheath is too large to be inserted. And in this case, I use this optical trocar with a conical shaped tip. And then I can insert this endoscopic sheath without damaging the fornix. I can go in. You see the posterior commissure, some hemosiderine residuals. And then what we do not make a dilation of the aqueduct. We just perforate this. There's no need that we dilate the balloon as we did in aqueductoplasty. We just want to have space for insertion of the stent. Because if you don't use a stent, which we did previously, you have a high risk of failure. So we use a 1.2 millimeter endoscope to inspect through the aqueduct to make sure we already have reached the fourth ventricle. You see Luschke, Marjan D. This was the fourth ventricle. And then we insert the stent via the working canal of the large lotoscope. So it fits through the working channel. And then we remove the endoscopic sheath. And then you see the ventricular catheter goes here, it goes to the shunt, and the trapped fourth ventricle came down. Trapped temporal horn is the same. We can make a temporal ventriculostomy in this area. I skip this for the sake of time, but this can also be done. And you see it's a good communication, but of course this area must be very thin and you must be careful because here are a lot of vessels, but it's an option for endoscopic treatment. Just John, short work to CPC. Is it a useful treatment? There's a study from Ben Worf and Abhaya Kulkarni, and they showed that ETV and CPC has the same efficiency like ventriculoperitoneal shunting, but has less complications like infection. So it seems to be a good alternative to shunting. But then there was a study in North America, a prospective study, and they found that CPC and ETV have a higher failure rate than shunting. And they also could not show that ETV alone is worse than ETV plus CPC. So it's still unknown, is CPC really an option? And when, in what special indications it's very useful. And there seems to be evidence that at least 90% of the coral plexus should be coagulated to be effective with this treatment. We have the experience of this child. She came from Saudi Arabia and she has severe ascites. She had a VP shunt and she came to us for shunt revision. But when we looked at the MRI, you see there seems to be a very hypertrophic coral plexus. So this seems to be one of the cases which is rare, but which can have an overproduction of CSF as a cause of hydrocephalus. So what we did, we used a rigid scope because there is a larger working channel and the coagulation is more effective. So we made 2 boreholes. And when we looked into the temporal horn, you see this hypertrophic coral plexus. This is really unusual. It's almost like in papilloma of the coral plexus, but it's just coral plexus. So we coagulated initially with the bipolar diathermy probe, but it was also insufficient. And then we used the bipolar forceps. But still then, we coagulated on each side 1.5 hours. So the plexus was huge, and it took a lot of time for coagulation, but I think you should coagulate the total plexus in the lateral ventricle. So all what you can reach, temporal horn, as well as in the central part, should be coagulated. Of course, we do not coagulate in the third and the fourth ventricle, but all in the lateral ventricle should be coagulated. And then you see the ventricles came down inside, and also after 2 days, ascite is completely gone. So very quick response. So this was really a case where CPC was useful. So when do we use endoscopy and hydrocephalus? If I see occlusive hydrocephalus, I do endoscopic surgery, even if the child would be lower, younger than 6 months of age. But of course, if the child is older than 6 months, I think it's a clear indication. If it's less, we have to explain to the parents it can work, maybe not, and then you have to find the decision together with the parents. But if there is post-hemorrhagic hydrocephalus or post-infectious hydrocephalus, if they are below the age of 1 year, I think shunting is more reliable. Communicating hydrocephalus, we had a very bad experience, so it's not working in our hands. We use it for the treatment of maculated hydrocephalus to create a simplification of the shunt. And of course, we try it in the case of shunt failure when the cause of the hydrocephalus is occlusive. If the shunt failure is in a communicating hydrocephalus, you also had no experience. But if we are in doubt, we try endoscopy first. And this is also a result of this literature review and evidence-based guidelines which were published by the North American pediatric neurosurgeons, and they found that shunts and ETV demonstrated equally outcomes in clinical etiologies they studied. So it's still, both are an option. So I think in obstructive hydrocephalus, an endoscopic treatment is treatment of choice. The success of ETV is clearly less than in adults and older children, and the success rate is age and etiology dependent. Thank you for your attention.
Well, thank you, Henry, for such a brilliant lecture. As always, we all benefit from your wide experience. I will try to crystallize some of the questions that have been posted by the audience. What is your take whenever you go below the floor of the third ventricle and you are trying to release these adhesions? Do you think there is a difference between using scissors versus using a balloon to get rid of these adhesions below the membrane?
Yes, there are many cases, especially in adult patients, where these arachnoid membranes are very tough. You cannot rupture them. There's no chance. It's a thick arachnoid. So you need scissors to open it. Of course, if you have a very thin arachnoid membrane, then I use also a balloon catheter to dilate it. But in many cases, it's not possible. Of course, if you have a very narrow prepontine cistern, you cannot go in with your endoscope in the depths. Then of course you cannot do it. But if you have sufficient space to go with the endoscope, and the little Lotta has a diameter of 3.6 millimeters, you can go down in front of the prepontine, or in front of the basilar artery, and can open it. So it depends from the rigidity of the membranes. If they are soft, you can use a balloon, but usually they are very firm and you need the scissors.
Okay. The next question, probably from many of our viewers who are thinking about starting in endoscopy or making a choice of which equipment they should acquire. Would you point out the advantages of using the sheet? I guess you have pointed some of them, but in your experience, if it's adequate to start out using an endoscope with a sheet and getting used to have this working channel space?
Yeah, I think it's very helpful. Of course, you should find your own way. There are also people, they don't like it. They always take a peel away sheath just to give a pass into the ventricle. For me, it's really like a tool. Sometimes I displace a tumor to get access to the attachment of the tumor to the ventricular wall. I can can have a colloid cyst, I push it away. I have a bleeding at the telechoredia, I go in and I take it as a retractor for the fornix to get access to the telechoredia in colloid cysts, for example. So there are multiple ideas to use it. Many people are concerned because they say, no, the edge is too sharp and you damage the structures when you go in. That's why I have showed you, I go back with my endoscope into the sheath, and then I see the whole margin of the sheath. And then on a direct vision, I can guide this sheath into a cavity. For example, when I want to go into the third ventricle, I see the choroid plexus and I see also the fornix. But I can understand if you have a different experience and you don't need it, then you don't, it's not a must to use it. But for me, I find it very helpful.
I think at least in our experience, it was a big eye opener of having the sheet to work around membranes and pulling out fragments of tumors. So it's a great advantage. Also, there was this question from the audience. What is your advice on coagulating the floor previous to perforation or after you have perforated if you coagulate the floor? Of course, we saw in many of your presentations that you obviously didn't do it, but people are wondering whether this is something that you would advise.
Yeah, no, if possible, don't do it. I did it in a few cases, especially after infections when there was a very sick floor. But in general, I take the deck forceps. This is a forceps with the teeth outside. I use that instrument to perforate the floor. You know, sometimes the floor is very firm. And if you take the balloon catheter from the beginning, it may slide to the one side or the other, and then you make a hole laterally of the midline, somewhere where I don't want to go. And if you have once created a hole, you always slide in the same hole. If you take a rigid instrument, you can really define the midline and you make the perforation where you want to have it. And for me, this blunt tip deck forceps is the best. And then afterwards, I take the balloon. Sometimes if their floor has thick membranes below, I also have to use scissors. But energy sources, I try to avoid whenever possible.
Actually, Henry, we have always used diathermy to open the floor. And, and I'm very comfortable with it. So whatever you're used to. So some of my colleagues, even in our center, do not like to see it. But, you know, I was trained in Birmingham, and Birmingham people did that, and I just learned it that way, and have always done that, and haven't had any trouble. Touch wood. Yeah. So let's see.
One reason not to do is it because sometimes you have a floor which is not translucent, and sometimes you have perforators. They make a loop anteriorly, and if you coagulate the floor and the perforator is directly under this floor, you may damage it. If you make a blunt opening, you will push the vessel away. It will never have a problem.
The idea is that you, same idea that you burn it halfway, you don't burn it all the way, and then you use whatever instrument you want to use so that you make sure you stay in the midline.
Yeah. Okay. There are many options, as always.
I would also like to point out, as a tip for trainees, that whenever we do an ETV on a patient which has experienced shunt failure, if possible, and if you're experienced enough, we usually try to at least release the catheter, which is, in most of the cases occluded by choroid plexus. So after the ETV has been performed, we coagulate the choroid plexus around the catheter and we try to release it, even if we're not taking it out, because if for whatever reason the ETV won't work and then you have to revise it, then you don't have to worry about pulling out that catheter and inducing bleeding within the ventricle. So at least in our practice, that's one of the things that whenever possible, we attempt to do that. It takes just a couple of extra minutes doing that. And one of the other things that I wanted to point out is that whenever you're putting in a catheter, as you said, usually this will only go through the working channel of the big lota. And also because of the maneuvers that you have sometimes to perform, whether perforating a cyst or the membrane of a craniopharyngioma and so on, you have to always make sure that the length of the catheter and the stylet will be long enough for you to manage it from the other side, on the other end of the lota. So always stick out a catheter before you put it into the brain and make sure that you will be able to maneuver it. Any tips on that, Henry?
No, when we remove it, in this case with a microculated hydrocephalus, I went in with the endoscope and I looked, is it attached? And the one of the right side was severely attached. So as you recommended, I coagulated everything, cut it, and then we pulled. My assistant was pulling from outside, and then you can watch like the catheter is disappearing. But it's very important that you don't make a blind. I think it is difficult. Even if you coagulate, you should not blindly pull on it because it can still be adherent to some structures. So that is, I think, the problem. Yeah.
So other thing you can do for that is put an stillet inside the ventricular catheter and then coagulate the stillet itself and then slowly manipulate it, and it works very well. And that was a routine that we used to do.
But I'm surprised, Samuel, because you need a high energy because it's so long. The stillet is so long. It's not only the small tip which is in contact. So I guess you have to burn really with high power, huh? Or not?
No, I think no. Just a routine, and because generally the shunt catheter we used to put is 6 centimeters is the average that we use. We didn't have any trouble.
So I always look from outside, and then the system pulling, you see like it's disappearing.
Well, if any of the viewers is interested, as you know, the IFNE is slowly building an online encyclopedia where you can go in and watch some of these procedures. I have posted myself one of the coagulation of the catheters. So you can actually look at the effect of diathermy, looking from within. So quite interesting. So many of these techniques can be seen from multiple surgeons at the IFNE online encyclopedia. So I think it's now time for Professor Chandrasekhar Depujari to continue with the next lecture. As all of you know, Professor Depujari has been one of the past presidents of the International Society of Pediatric Neurosurgery. He's also one of the champions of endoscopy in India. He practices at the Bombay Institute of Medical Sciences in Mumbai, India. And without further introduction, I will let Professor Depujari elaborate on arachnoid cysts in the temporal and supracellular region.
Thanks, Adrian. And I must thank Salman for this opportunity. I thought, Salman, you've been going very strong, and I was wondering if there is already a webinar fatigue that has set in, but you seem to be going strong, and there seem to be a good audience. You are really arranging very good webinars, and thanks for this opportunity. Basically, arachnoid cysts are a rare disorder, and if you look at the National Organization for Rare Disorders, it would tell you that they appear from arachnoid membrane and the exact cause is unknown. If you look more in details about what is an arachnoid cyst, it certainly seems that they are within the two layers of the arachnoid or between the arachnoid and the pia, and the pathogenesis of arachnoid cyst is probably because of splitting or duplication of the arachnoid membrane. Therefore, they are really congenital malformation. In United States, almost 3 children out of 100 born are with arachnoid cysts, and there is a male predominance. And when they become symptomatic, it could either be due to raised intracranial pressure or they could cause impairment of cerebral perfusion. How frequently are they seen? There's a huge study of MR images done in children. More than 11,000 patients studied, and they have found that 2.6% prevalence rate in children. And if you look at their natural history, you can see that no patient older than 4 years at the time of initial diagnosis has had cyst enlargement or demonstrated new symptoms. So most arachnoid cysts, and about I think the percentage is less than 10%, which shows some increase in size and may become symptomatic. If you look at the adult population, you will find almost 48,000 patients studied over a period of MRI studies which have been evaluated. have shown about 600 patients. So 1.5% is the incidence in adult patients. And if you look at they becoming symptomatic, only 2 patients developed new or worsening symptoms over the follow-up period. So it is mainly a disease which becomes symptomatic in children, and that too in a small percentage of children. In terms of clinical patients, this is a paper from Southampton which has shown that uh, in their experience, out of 425 patients, which uh, 425 patients out of 485 patients were asymptomatic. So almost 87% patients are asymptomatic, even when they have presented for some reason or the other to the pediatric neurosurgery department there. So really, judging by the existing literature, growth of an arachnoid cyst after early childhood is extremely rare. Most colleagues advocate a strategy of repeated neuroimaging procedures, but usually, probably it is not required unless the patient is becoming symptomatic, or there is some increase in the head size. In our, we have recently evaluated, and uh, our paper is about to get published on arachnoid cyst experience, 57 patients, out of which 6 presented below 1 year, 30 presented below 10 years, and almost 42 patients out of these were in the pediatric age group, while we had 15 patients in the adult age group as well. Common locations, Sylvian fissure being the commonest amongst these. And if you look at the asymptomatic arachnoid cyst location, which was given in that paper of presentation of arachnoid cyst, you would find that almost 34% are in middle fossa and about 33% in the posterior fossa, and rest are distributed at other. In our own experience, we had 16 temporal, 13 retrocerebellar, and others were in diminishing order. Supracellular cysts were 7. Clinical features which can be attributed to the mass effect either from the in the arachnoid cyst rupture or cyst hemorrhage can be seen. So you may have signs of raised ICP. You may have very rarely cranial nerve deficits or Perinaud syndrome, and you can have endocrinopathy, seizures, and you can occasionally have a patient coming in like a emergency with a cyst rupture or a cyst hemorrhage. In our patients, we had signs of raised intracranial pressure in 32 patients, and others have presented with varying symptoms. Now, there is a paper which has come from China recently, which has actually divided this into 3 different kinds of arachnoid cysts: completely communicating, incompletely communicating, and non-communicating. And this classification is based on intrathecal contrast in MRI. And this is quite interesting, as we'll talk about it a little later. So basically, the indications for surgery in arachnoid cysts are raised ICP, presence of subdural or intralesional hemorrhage, increase in the size or volume of the cyst on follow-up. Accompanying hydrocephalus can be an important indication in early childhood. Seizures is a questionable, as we'll talk about it later. Focal deficits and endocrinological manifestations again is a questionable indication. If you look at the psychomotor development, you find that patients who have actually been treated for some other reasons, like backache, have been studied for neurodevelopmental studies. And arachnoid cysts seem to impair not only the basic cognition, but also executive function in these patients. And some of these patients who have undergone surgery have had reversal of these phenomena. So there is probably an indication even in adults or even in patients who have had a slow decline in their cognitive function, which has been considered questionable by most people, but there seems to be some evidence for it. Coming to the 2 specific cysts which we are going to talk about it today, temporal cysts were first described into 3 types by Galassi, depending on their communication, and those days were the contrast, intrathecal contrast on MRI, and the size. So size and communication were the 2 criteria on CT cystoscopy, and this has given us the type 1, type 2, and type 3 being the largest and non-communicating. So how do we treat this patient? This is a young child who was born with slightly large head, and therefore they did a MRI scan which shows a arachnoid cyst, and you can see that there are hardly any signs of mass effect, and the child was neurologically normal. So therefore this child was kept under 3 monthly observation, and at about 6 months the head started increasing a little bit. The cyst has increased substantially, and you can see that there is a contralateral shift and there is a definite mass effect. At this stage, the patient was then treated. So how do you treat these patients? I think there are several possibilities. You can do a craniotomy and a fenestration with some marsupialization of the cyst. You can do an endoscopic fenestration. You can do a cystoperitoneal shunt. You can do both simultaneously, or you can do one followed by two, depending on the response. There is a systematic analysis which has been done of all the three procedures. Cystoperitoneal shunts in 90 patients have been followed up, craniotomy and cyst excision in 160, and endoscopic fenestration in 50 patients. This was in 2011. And there you can see that all the three varieties work reasonably well, and you will find almost 88% success rate in craniotomy with microscopic excision, over 70% in endoscopic, and almost 96% improvement in cystoperitoneal shunt. So cystoperitoneal shunt was probably one of the early treatments described, and Arai has way back in 1996 wrote up about 77 patients, and they have actually come to a conclusion that though this is a valid method, they have seen that some of the patients became shunt dependent, and these patients, some of them have also been reported to have developed acquired Chiari malformations, and therefore it is not encouraged to do a cystoperitoneal shunt unless all other methods are either not possible or have not worked for the patient. The earliest series with endoscopy was, of course, by Dr. Pernesky and Hoff, and they used this in about 36 patients with a overall success rate of 70% published in 1998. And soon thereafter, Soviden published from United States a similar kind of results in his 33 patients, where they have shown that there was 97% success rate, much better than what Pernesky's reported. Soon thereafter, Henry and his colleagues have written up about 61 patients with almost an overall clinical success rate of 90%. And this treatment has become obviously more and more popular. Some other ways of doing this surgery have been described. He Dong Cho described to do a extra channel kind of maneuvering so that you can do it in a more versatile manner and still got the same kind of results. And Gangemi from Italy also produced almost 75% success rate in at the lower end for some interhemispheric and Sylvian fissure, but in other arachnoid cyst, he has shown more than 83% success rate. If you look at the analysis with craniotomy and microsurgical fenestration or partial excision, you can see that success rate of over 90% has been described by these three groups. This is from, I think, Denmark, and they have shown that in their hands, craniotomy worked better than endoscopic decompression. And this is a paper with a large number of patients which has come from Neckers, which has actually shown that microsurgery is probably the more effective treatment with longer effectivity and fewer complications compared to shunting or endoscopy. So microsurgical cyst excision obviously can give you a good visualization. Multiple fenestrations can be done. You can marsupialize the cyst. You can probably excise the cyst to some extent. And you can manipulate ECOG monitoring, especially if the patient has presented with epileptic presentation, and it avoids shunt-related complications, but is, of course, more traumatizing and more time consuming. While endoscopic fenestration is, of course, minimally invasive, less time consuming, and comparatively less blood loss, and multiloculated cyst can also be safely and more effectively treated. It of course requires trained personnel, equipments, but you are also worried about reformation of membrane. What is our experience? This is a small child. Again, this is a child like what I showed earlier, a child who came to us at 3 months of age, had a smaller cyst, and then the cyst grew and the head size grew. And at this time, we decided to go ahead with surgery. And this is an endoscopic. We perform a mini craniotomy at the edge of the cyst, and then we pass the endoscope, and you can see a fenestration has been done between the third nerve and the tentorial edge, and then this is being enlarged. I usually don't like to use balloon for arachnoid cyst in the temporal fossa if the nerve is very close to the, so depending on the space available, you can use either scissors and probably make larger cuts, or you can use the balloon to dilate this. But you must, like third ventriculostomy, you will always find a second layer of arachnoid before you enter into the prepontine space or the interpeduncular space. In this particular patient, we had some technical issues, and I'm showing this just to tell you that through the same opening, a microsurgical approach can also be done. So the question is that fenestration seems to be the main theme. If you do it endoscopic or microsurgical depends on what you have available. And I think there is very little difference. And I personally prefer doing endoscopic, but on that particular day, we had some failure of equipment and we had to turn to microscopy, but without any hassle. Through the same opening, you could go and you could perform this. So I really do not think there is too much of difference between the two techniques. I think endoscopy in experienced hands can do virtually the same thing as you can do with microscopic surgery and vice versa. Does the size matter? Yes, it seems that this particular paper has shown that how big fenestration you make probably is dependent on how much improvement you get. And in larger fenestrations, they have shown that 95% success rate has occurred whenever they have made. They have not actually given a definite measure, but I think 4 millimeters should be the minimum opening into the fenestration. That's what this paper is trying to say. Volume changes in the cranial arachnoid cyst following successful endoscopic or microscopic fenestration has been observed. Is it directly related to improvement of the patient is not really very clearly mentioned in any of the papers, but there is a significant reduction in arachnoid cyst after successful endoscopic fenestration. In our own experience, we have had almost 92% patients had decrease in their cyst volume, which was statistically significant. What about the fact that should you be operating and what should be the indications for operating? Dr. Tamburini, one of the active members of ISPN, did a survey some time ago, and they found that there were several practices prevalent, but cyst marsupialization was preferred in the more recent literature than earlier. And the only diagnostic investigation which influenced surgical indication was actually the EEG, which showed location. So for seizures, many people use this. One of our patients where we did it for a seizure, and you can see actually that there is a good reduction in the cyst size, and this patient in fact had complete disappearance of disturbances on ECOG after the cyst was excised and has remained well for several years now. Dr. DiRocco actually in his editorial comment in Child's Nervous System has written a special note that though we all operate on Silver-Fisher arachnoid cyst, do we have enough evidence to do that? Because he feels most of the headaches are not characteristic of ICP. Seizure disorders, most of the temporal lobes in these patients have some dysplasia. Psychomotor retardation has not been shown to remarkably improve with reduction in the cyst size. And he has shown that there is no consistent volumetric decrease of the cyst by any of the procedures. and prophylactic operation to avoid subdural hygromas or hematomas has not been successful, as after shunt cyst fenestration there are cases reported with bleeding, and therefore the risk, especially in children, the risk of sport-related brain injury is often discussed for arachnoid cyst, but most people, and there is a consensus that probably they should avoid contact sports, but they should be otherwise allowed to uh, uh, play outdoor sports. Uh, I think a more recent systematic review has told us that probably today the endoscopic fenestration has as good a success rate and very little complication rate. And in terms of short-term and long-term complication, it has probably the least morbidity and mortality of all the three procedures. How about adults? Chemomate series, which had patients in all age groups, have shown that there is improvement in seizure outcome. There is improvement in, though it is seen only in 1/3 of the patients, there is a good outcome even in behavioral outcome is much better, and raised ICP is of course significantly better. If you look at the other papers which have written about the adult patients, they have shown that decompression certainly yields a substantial clinical betterment in these patients. This is one of our patients, a 29-year-old executive who came with intractable headaches. We asked him to wait, and on third follow-up, eventually after about 8 months, he decided to get operated because headaches were not responding to any kind of treatment. And again, we have done two fenestrations between the uh, tentorial edge and the third nerve, and between the third nerve and the carotid. And I usually check this up with a 3 months follow-up cinecystonogram, which shows a very good flow here with some reduction in the cyst size. But this patient says that his headaches improved remarkably and his improved his work performance. So even in adult patients, I think there is now enough papers to tell us that there has been significant improvement, and the results indicate that surgical intervention is definitely an effective approach to reduce or eliminate symptoms in adults as well. What about patients who are asymptomatic? Do we observe them regularly? Usually not, except for very small children. We do not observe them regularly, but occasionally you find a patient who presents with something like this subdural hematoma. This is a 14-year-old girl who during her school exams actually suffered this, and this had to be done as an emergency procedure. The question is, should we do a fenestration at the same time in the cyst or not? Most people, when this question is put, usually say yes, but this patient now about 9 years after the surgery has not shown any other symptoms and has remained stable in her cyst and her symptoms, so we have not treated her further. Another one with subdural hygroma, something very similar. We had to drain it once and it has settled down, and the patient has never come back again for follow-up, except for 1 year MRI follow-up, which showed that it had completely disappeared with a very small cyst remaining. What about intrauterine detection of arachnoid cyst? We have about 7 patients now whom we have followed up to out of which 2 patients required surgery immediately after birth. This is one patient where the cyst had substantially increased with some mass effect, and we actually did a double fenestration here, and it worked quite well for about 6 months, but then again the head size increased. At this time we decided to put in a shunt, and that seems to have worked quite well, as the cyst has virtually disappeared after that. Let's talk about supracellular cysts. Supracellular cysts are typically cysts which develop from reduplication of the mesencephalic membrane, and you will find 2 varieties described by Miyajima, which shows you that the basilar artery lies within the cyst or it lies in front of the cyst. And those where it lies in front of the cyst need definite treatment. The ones where there is a communication with the prepontine cistern do not really require treatment most of the time. After Miyajima's paper, there is another paper which has come from Necker, where they are putting a third variety, which actually shows that there is a defect in the mesencephalic leaf of the Liliequist membrane, and you may have that. And uh, there they have described that those patients may not require treatment. So identifying what kind of supracellular cyst you are dealing with is very important. The best treatment because of the trajectory is to do an endoscopic fenestration like had been done for this patient. And there is another variety which has been recently described by a South American group, where they say that it may be communicating not only with the prepontine space but also with the anterior spinal space, and again these do not require any treatment. So basically, you have to differentiate it from other cystic supracerebellar lesions, and it is fairly straightforward. Most of the lesions have the characteristic MRI finding. So after MRI, you can be pretty sure that you are dealing with an arachnoid cyst. And as we talked about, the only variety where you definitely need to treat is the spatially compartmentalized variety, which is not communicating with the uh, prepontine space. So what about endoscopy versus microsurgical cyst excision? I think in this variety, the definite advantage of endoscopy is quite well proved by several papers. Gangemi has produced his paper. From India, Dr. Yadav has written up his paper, and we have similar experience. Mehmet Ozek has written about 34 cases where again they have had a very good success rate. And typically what you do is you would first open the cyst dome, and once you have opened the cyst dome, you enlarge the cyst opening. Once you have enlarged the cyst opening, you should actually look at the bottom and try to do something like a third ventriculostomy. You do a cisternostomy, because many a times a long-standing arachnoid cyst might cause not only a functional block, but also after you have opened it, the flapping membrane could block the aqueduct, and therefore doing only a uh, cystoventriculostomy does not work very well. It has only about 60% success rate, while uh, ventriculocystonostomy plus cystocystonostomy has almost 90% rate. Very rarely you can get a patient with visual failure. This is one of our recent patients. And these days, what we have started doing is to cut out a bigger area of cyst dome, so that it does not, uh, it can not collapse or block the aqueduct, etc. And it is always better to have a wider opening in that sense. And thulium laser seems to work very well to do such a thing, and allows us to remove this without causing any bleeding or without causing any side effects. And then of course you would go on to do a cystoventriculostomy like we are doing here. So this is the eventual picture. There is about 30% reduction in the cyst size in 3 months time, and the child has improved in vision substantially. As I was just talking about, the secondary aqueductal occlusion is important, and therefore a double fenestration is desired, which gives a much better result. There is a paper which has again tried to say the same thing. There is a feeling that aqueduct, if you can check that it is open, you may not do a cystocysternostomy. In one of our patients, we could not do a cystocysternostomy because the gap between the basilar artery and the floor was very, very small. And here, what we did was we actually put in dye, and we made sure that the dye was going in the subarachnoid space quite well, and therefore we did not treat this patient. So there may be a, situation where if you are unable to do a cystocystonostomy, you can probably check the patency of aqueduct at least to make sure that it will work well. There is another variety of cellar cysts which can sometimes be confusing. It is usually found in older people. It is not associated with hydrocephalus, and the pituitary is usually hypoplastic. These patients usually have hypopituitarism. And these kind of cases need to be treated by a endonasal approach, where you can actually open the cyst. And once you open the cyst, you will find that there is a ball valve kind of a mechanism, which you can see here. And this could be completely plugged, and a proper flap was put to cover this defect. And this has worked well for this patient and has uh, recovered her from her visual problems. This is the post-operative picture. I think I would not spend much time on other cysts, but quadrigeminal cyst is again endoscopically treatable, a very, very good indication for endoscopic surgery. Intraventricular arachnoid cysts are largely being treated by endoscopic approach now. And there are certain cysts where it is not so easily possible. But interhemispheric cyst, if you have larger ventricles, can also be fenestrated into the ventricle, like what we managed to do in this patient. Posterior fossa cysts are not always possible to be treated by endoscopy alone. In our 57 cases, we could do endoscopic fenestration successfully in 34 patients. We had to, I think, shunt one of these patients, and 3 other patients required a repeat procedure because of closure of stoma in our earlier period. And there have been 11 patients who required shunts. This is another chart which is showing complications, and we have had endoscopic fenestration has been associated with the least amount of complications, 16% complications, but usually temporary and minor complications in these patients. So I think concomitant hydrocephalus is something which initially we talked about. It was seen in about 1/3 of our patients. And Gordon McComb has written a very good, interesting observation that whenever you have associated hydrocephalus, you should probably consider a shunt along with fenestration at the same sitting. And should you be shunting the cyst or should you be shunting ventricle? Probably you should be shunting the cyst if the hydrocephalus is not marked. Otherwise, better to do a fenestration and then to do a ventricular shunting. This is the last slide I'm showing about the recent classification which has been talked about with MR cysternography, which has clearly shown that if you can show a non-communication, then your success rate of your endoscopic procedure is much better than if you have a cyst where the dye is going from subarachnoid space very freely into the cyst and vice versa. And therefore, probably this may be a investigation which can probably be used in patients which are questionable indications. ICP monitoring being another, which is used by certain groups, but again, not very reliable. So I would like to end by saying that surgery has proved benefit for symptomatic arachnoid cyst. Endoscopic fenestration seems to be the current favorite first line option, maybe followed by shunt if necessary. And cystoperitoneal or VP shunts may be the first option in very young patients with associated hydrocephalus and large head. Thank you.
Thank
Any
you, Dr.
questions?
Pujari. That was a brilliant presentation. As always, a very vast experience in the management of these endoscopic lesions. There are some questions from the audience in which I would like you to elaborate. From time to time, we have kids that come in with what seems to be a subdural hematoma. And of course, this has been a subdural that's associated with a bleeding arachnoid cyst. So what is your management on these patients? Do you attack first the hematoma and then later on the cyst?
Right. So I have had 3 such patients in my experience. And in 2 patients, I have, all the 3 patients, we first evacuated the hematoma. And in one of these patients, I have later date, about 3 months later, I have done a fenestration. I think in presence of blood, it is not very easy to do a fenestration unless you decide to do a whole craniotomy and microscopic fenestration. Because with endoscopy, I find that with even little blood, it is difficult to do. 2 other patients, one of them which I showed during this presentation, have not had any symptoms or no further increase in the cyst, and therefore they have not been treated at all. And in fact, there is a fourth patient which has presented only with a subdural hygroma. And again, after draining it once, it has remained stable. Patient has not required any further treatment.
I think one of the big lessons for trainees that you've pointed out is that if for whatever reason while treating one of these lesions, you don't feel comfortable enough of proceeding endoscopically, there is no sin in transforming this into an open or semi-open or endoscopic assisted procedure. You should be able to say, okay, I'm not it's gotten too bloody, or I am not sure of which structures I'm looking at, so it's time to convert to an open procedure and prevent doing harm to the patient.
Absolutely.
Okay, so in the interest for the audience, I will just share my screen briefly, and I will show you, can you see my screen now?
Yeah.
So we are looking here at the Encyclopedia of Neuroendoscopic Procedures. As you can see here, the address is neuroendo.net. This has been an effort in which you can basically browse through a number of procedures, not only ventricular, but even spine, endoscopic assisted. And in most cases, you have the opportunity to see at least 3 or 4 examples of each procedure in several surgeons. As you can see, some of these are mine, but you can see also some other authors. And I think there's, it's very educational to see how people do it in different approaches, in different settings. So I think there's a lot of added value looking at the encyclopedia. I guess we should now proceed to see the quiz. Imad, can you help us with that?
Imad,
yes, sir.
Thanks.
Yes, sir. Yes, sir.
And you can show us next week's poster as well.
Yes, very important to announce that because of the fact that next Saturday, it's the official IF&E weekend, we will leap forward one week later. So next Saturday, it should be the IF&E monthly presentation, and then we will resume our lectures on October the 3rd. Okay, so Chandra, would you like to take on your questions?
Yeah, so the question was, primary arachnoid cysts are congenital or are they acquired? And most people got it right, that it is congenital. You can have acquired cysts as well after some trauma or subarachnoid hemorrhage, or occasionally after low-grade infection. But what we are talking about today is really the congenital cysts. Second.
Can we go down, please? Yeah.
Yeah, so the second question was, the Galassi classification depends on size of the cyst or cyst communication with the subarachnoid space, or both. And again, most people got it right. Those who did not, I'm sure, will have learned today. So fairly straightforward questions. Actually, the third one is, supracellular arachnoid cysts are best treated with either shunt or endoscopic cyst fenestration, or cyst fenestration with cystocysternostomy. Again, almost 57% got it right. So I think fairly good performance. Associated hydrocephalus with arachnoid cysts needs early surgery of only cyst, or needs treatment of only hydrocephalus, or needs treatment of both. Again, I think most people got it right. So I'm really very happy. People were much better prepared. Probably I did not have to give the talk today. These are pre-meeting, isn't it? The answers are pre-meeting.
No, sir, they are post.
These are pre or post?
Post.
Ah, okay. So probably they have learned the right things then. Asymptomatic arachnoid cysts are seen in 3% of children. need follow-up in children below 3 years, unlikely to grow in adults, none of the above, all of the above. And again, I think a good majority, almost 60% plus people have given the correct answer that all the statements are correct. Thank you. Henry.
Okay, so I guess these are Henry's questions.
That is good. 1/3, 1/3, 1/3.
Henry, you never taught us right. Fix this,
Yes.
come on.
I see. Difficult. But according to the study, the prospective randomized trial, which is the only one which gives clear evidence, we have to admit that there is similar success rate. So it's not better and not lower. But it is only because of the hydrocephalus caused by aqueduct stenosis under the age of 2 years. So the study has shown that it's a similar.
I think this is very typical, Henry. I think there is a bit of a confusion here. I mean, when we say that endoscopy is better, what we are trying to say is it is as good as shunt. And I think that is not as well understood probably.
But the success rate in terms of treating the hydrocephalus,
yes,
it's the same. The first study, the 1-year follow-up, has even shown that shunting was better. You know, there was a higher success rate in the first year shunting, but after 5 years, the quality of life and also the development of the kids in the psychological conditions were similar between shunting and the ETV. So I did not brought the message correct.
Okay, next.
At least that one everybody got. Never be at the thinnest part because it is usually in between the mammillary bodies, and then you are easily behind the basilar. You can tear one of the perforating arteries. And the lateral border of the mammillary bodies? No, I think 83% got it right. It should be usually in the midline, halfway between infundibulary recess and mammillary body. It should be in front of the basilar. That is very important.
Okay.
Again, 50-50. But so far, there's no evidence that CPC really improves the outcome. There is this, if you look at Uganda, you may say, yes, CPC is a valuable addition, but the study in North America has shown that's not advantage. So that's why it's really difficult. And also, I have talked to Joachim in Hamburg, and I think they did 12 kids with CPC in the post-hemorrhagic hydrocephalus, premature, no success. So I think for these kids, shunting is still the better treatment option. Of course, if you have a case like we had with this hyperproduction, then it is valuable. What are negative predictors? Age below 6 months, for sure, negative predictor. Infection, yes, negative predictor. Severe fibrosis, negative predictor. And aqueductal stenosis is not a negative predictor, but it's a good predictor. So at least this one is very good.
Brilliant. Ahmad, do you have the 2 webinars to show for next week? We actually have this is the one which is going to be coming up on the 3rd of October. And we have our 2 friends who are again great speakers, just like today's speakers. I think last week's speakers were great as well, and we had a really good time today. We really enjoyed it as well. And Ahmad, what else? We have the appreciation ceremony for WFNS, which is next Wednesday, same time. And we have a trauma symposium in which the chairs of the spine, the trauma committee, the peripheral nerve, and the pediatric committee will give talks regarding different traumas. And then we have the president WFNS and the president-elect, along with the coordinator of WFNS committees giving talks as well. So everybody's most welcome in that next Wednesday. And then I think on 27th, we have Ed Benzel. This is the World Spinal Column Society webinars, which is once every 3 weeks. He's going to be talking about cervical myelopathy and his journey. And Greg Trost from Wisconsin will show some cases. We have Paolo Pereira and Nicolai from Belfast moderating these sessions. So all are most welcome. So can we have a photograph? Can we all switch on our videos, please? And smile. Pretend. Henry, you can smile as well. It's okay. Smile, everybody.
Jeez. Or bleeding.
Teaching us third ventriculostomy with bleeding. Okay, are we done, Imad?
Yes, sir, done.
Okay, brilliant. Chandra and Henry, few words, and then Adrian, and then we'll sign off. Chandra?
Well, I think it was a nice to see Henry's cases. I must say that there was some learning there for us as well. And one of the big advantages of these webinars is we are all learning from each other. And I hope that some of the principles which we talked about and practical tips will be useful for all the participants. Thank you for the opportunity again.
Yeah, I also want to thank everybody to join us. I think it's a very good opportunity in these bad times that we at least see us virtually. Of course, I would love to see you face to face, have a good beer with you. But at that time, I think it's a very good initiative. And I, again, want to thank Adrian and especially Salman, who's doing so many webinars. I wonder why he's doing his clinical practice and why is he doing sleeping.
Absolutely.
Because you can turn on the screen and Salman is still there. It doesn't matter. It's spine, it's ventricular tumors. It's amazing.
Right.
So thank you, everybody. And of course, also we learned a lot of it. So Chandra, was good seeing you. And I hope we see you soon again. Have a nice weekend.
Adrian?
Well, I think I must share Chandra's and Henry's comments. And I think this is a very exciting time for learning. We hope that this pandemic will be over soon and we can resume our workshops worldwide, wherever you may be, whether in Asia, the Americas, or Europe. And please spread the word on this series. We are trying very hard to emphasize on tips and tricks for trainees and young neurosurgeons. So thank you again, Salman, for hosting us. It is with great pleasure that we carry on with these lectures.
So thank you, everybody. Thanks, Adrian, our two brilliant speakers today, and hope to see you guys next week, next Wednesday, and then the following Saturday. And we have the IFNE WFNS endoscopy as well the following Monday as well. So guys, we also have a WFNS neuroanatomy sessions on 29th and 30th as well. So it's going to be good fun. Thank you, everybody. Bye-bye. We'll see you soon.
Bye-bye.
Okay.